All right, perfect. So welcome to our final Pharm review. Again, it's kind of split between drugs for different body systems, drug for different psych disorders, etc. So for my St. Pete group, this is what is new content. Okay, this is considered quote unquote new content for you guys, meaning I haven't taught you it yet. Okay. So we are going to first be talking about transplant, vaccines, and cancer medications. All right. Just want to make sure I have all my notes in order. So, the goal of immunosuppressive therapy is to suppress the immune system to prevent the body from attacking itself or the transplant in the case of transplant medications. We are trying to essentially get rid of self versus non-self. The body saves itself and it attacks what it deems as non-self. In many autoimmune disorders, the body actually identifies its own tissue as non-self. So the whole goal of immunosuppressive therapy is my body's no longer going to be able to determine self or non-self, so it's not going to attack anything. But the important thing is we need balance, okay? We need to make sure that while we are not attacking our own body, we're not completely susceptible to infection, okay? Yes, question. I see someone raise their hand. You can unmute yourself, pop it in the chat. I see someone raise their hand. Okay, it might have been an accident. But if you have any questions, pop them in the chat, unmute yourself, whatever you need. Okay, essentially, we've got the induction phase versus the maintenance phase. In the induction phase of immunosuppressive therapy, this is very intense. We do it early post-op, usually heavy hitter IV meds. Okay, it's very important because we're trying to prevent that acute rejection phase. When you're on immunosuppressive therapy, after that induction phase, you will be put on the maintenance phase. This is lifelong and usually PO. Our prototype example would be cyclosporin. Okay, cyclosporin. So let's talk about our 3 bullet points for cyclosporin. This drug is very hepatotoxic and nephrotoxic. Therefore, we are going to assess your LFTs, which is your liver function, and your your kidney panel, your BUN, and your creatinine. Because this whole goal is to stop immune reactions, our patient is very susceptible to infection. So we're going to monitor for signs and symptoms of infection. Remember your general immunosuppressive therapy protocol. Avoid live vaccines, loud crowds, kids, throw your toothbrush in the dishwasher. That's an NCLEX thing, okay? Keep healthy. Interesting thing about cyclosporin is it's contraindicated in grapefruit juice. Grapefruit juice contraindicated in a lot of things. All right. This drug can also cause gingival hyperplasia, so look at your patient's teeth. Okay. Our vaccine, our varicella vaccine specifically, is for chickenpox. While it is going to give us immunity from chickenpox, it's going to be contraindicated in immunocompromised individuals, meaning we just talked about cyclosporin. If you're on cyclosporin, you cannot get the varicella vaccine. Okay. Just review your proper administration technique, subcutaneous versus intramuscular. Note that this vaccine has to be taken 4 weeks apart other vaccines, okay? And it's going to prevent chickenpox. We all know that general flu shot feeling you get where you get pain, fever, malaise, etc. That's just our vaccine considerations. All right. However, if you are having an acute illness of something, such as active TB, now is not the time to get a live vaccine either, okay? Moving into our chemotherapy portion of things, we have our alkylinating drugs, specifically cyclophosphamide, okay? Our big concern with cyclophosphamide is while it's very good at treating lots of different cancers and tumors, it can cause what is called hemorrhagic cystitis. This is why it's very important before starting this medication, we give Mesna, okay? We're also going to tell our patients, drink lots and lots and lots of fluids, and get on a strict voiding schedule. Pee every 2 hours. We are doing whatever we can to avoid your bladder from bursting, okay, which is a side effect of this medication. Additionally, all cancer drugs, usually via IV, are vesicant, so watch for extravasation. This little bit I have about toothbrushes, it's just because we want to remember our big chemotherapy issues. We have some mucositis, okay, some irritation. So soft toothbrush, avoiding high purine foods, and citric acid is very, very, very important. Alrighty, up next we have doxorubicin. Think ruby. It's the color red. Okay. However, and with the ruby, think red. It can turn your urine pink red. So that's just mnemonics I really like to use. Contraindicated in foods with turmeric. So just kind of keep that in mind. More of your nursing considerations for doxorubicin is after a patient receives doxorubicin, essentially they are walking biohazards for about 5 days after their treatment. So we must use PPE when coming in contact with urine or bodily fluids. All right. I have this little equation down here. You're calculating your ANC. This is just what we can do for patients on chemotherapy to make sure that we have not absolutely tanked their white blood cell, so that a little infection is not going to be super, super, super serious. Also with ruby, think like the red heart I have. It is pretty cardiotoxic. Okay. The temp above 100, that's just what we have to do for patients that are on chemotherapy, on immunosuppressants, because a fever over 100 for them is going to be very, very severe. Meanwhile, fever over 100 for me, I'm not immunosuppressed. I'm okay. All right. Up next is vincristine. This is our plant alkaloid. Okay, our plant alkaloids usually have hypersensitivity reactions, so it's important we pre-treat with Benadryl. We all know the hallmark signs and symptoms of hypersensitivity reactions, flushing, itchiness, hives, etc. All right, I would really focus. This cancer drug must be pre-treated with Benadryl. Okay. Again, neurotoxic, report abnormal bleeding. Those are just general good considerations. So again, for St. Pete, this is new for you. It might not be new for Tampa, but we're going to be talking about reproductive and urological drugs. Okay. Up first is our estrogens. These are usually used for postmenopausal discomfort. Okay. However, your estrogen therapy really isn't the safest around, okay? Why? It can cause bleeding abnormalities, and what's even worse is it can cause clots and thrombotic events, such as your DVTs, pulmonary embolisms, etc. Therefore, it is super important that we teach them to avoid other activities that increase your risk of a thrombotic event, such as smoking. Additionally, this puts you at risk for our common female cancers, breast cancer, and cervical cancer. So just keep that in mind. Our estrogen contraceptives, these again are hormonal medications used to prevent pregnancy. However, our progestin contraceptives are generally safer. They lack estrogen, and by lacking estrogen, they're not going to have as severe risk for clots, cancers, etc. All right. Just note that certain drugs, such as antibiotics and herbal products, decrease the effectiveness of oral contraceptives. It's so important to educate the patient on other forms of contraceptives and knowing that they have to take this every day in order to prevent pregnancies. There's different ways that these drugs can work. They can increase your cervical mucus, stop you from ovulating, etc. If we are trying to ovulate, we're going to give the patient clomiphene citrate, okay? This is going to help promote ovulation, but it's one of those drugs where, you know, how we say all psychiatric drugs can put you at risk for suicide. All antidepressants make you more suicidal. That's a risk factor. Same thing. While this promotes ovulation, a big side effect is ectopic pregnancy and that's a medical emergency. Therefore, it's going to be contraindicated if those have endometriosis and ovarian cysts, because it's really going to put you at risk of this ectopic pregnancy. So a pelvic exam prior is very, very important. Up next, we have our testosterone, our androgens, okay? This is usually used for patients that have testicular failure, delayed puberty, or just want more androgens. However, it will be contraindicated in cases of cancer and BPH because it's going to further worsen that, okay? Additionally, with your testosterone, it can cause lots of problems if a female comes in contact with it. So females should not be handling this medication. If so, they must wear gloves. It's also important to do a good urinary assessment on these patients. Like I said, this is going to worsen BPH. Why? Testosterone acts on the prostate. So observe for prostate changes and urinary changes. This drug also will increase your cholesterol. Now we're kind of tiptoeing into our BPH meds. So this is going to be super helpful for your BPH portion of your complex health exam. So up first, we have bifenthral chloride. This is really good for urinary retention, okay, especially in patients with that BPH or that just have like some neurogenic bladder. I know we talk about multiple sclerosis, having issues with peeing. So kind of just keep that in mind. However, our main side effect is bradycardia. Therefore, before administering, we check their heart rate and blood pressure. What do we do if their heart rate tanks? We administer atropine. Up next, we have finasteride, another good drug specifically for BPH because it is going to help us really. We know that increased PSA will put you at risk for BPH or worse than BPH, so we're going to try to stop those PSA levels from rising. This is contraindicated in erectile dysfunction meds, and again, women should not be handling male medications, okay? This medication is for BPH. Dudes got prostates. Women should not be handling this medication, especially if they're pregnant or trying to become pregnant. It can alter fetal development, and it can pose fertility risks to mom, and we do not want that. Okay. Up next is tamsulosin, really good drug for BPH. Unfortunately, a big side effect is orthostatic hypotension, and it can cause some performance issues. Okay. However, it's important we rule out prostate cancer first. It's just going to help us relax the prostate to improve voiding, because we know that prostate is pushing up against the urethra, thus impacting the urinary stream. Now we've got Viagra. It is a drug for erectile dysfunction. Big side effect is very bad headache and flushing. Okay, absolutely contraindicated in nitroglycerin. If you take nitroglycerin and have taken an ED med, you will probably pass out. Okay, you will probably have a cardiac event. It can kill you. Okay, so you take this medication before 30 minutes to 4 hours, before sex. No food, full glass of water. It can cause dizziness and headache. So just kind of keep that in mind. So now we are going to do the old content, what we are familiar with. So St. Pete, we are going to start at the top of Professor Frolov's blueprint and work our way down, starting with some of our fun cardiac drugs. So up first, we have epinephrine. This is used for patients that are having anaphylactic shock. Okay, it's going to promote that fight or flight in you to kind of help revive the patient. It's going to increase your heart rate, your blood pressure, pupil dilation, promote airflow, dilate the airways, etc. Therefore, our signs and symptoms are going to be our flight symptoms, that fight or flight. So we're going to assess for tachycardia, hypertension, palpitations, etc. After administering epinephrine, we must do frequent vital checks. Up next, we have our friend metoprolol. Metoprolol is a selective beta blocker, meaning it is only going to work on the heart. When we think of our beta adrenergic receptors, think one heart is beta 1, beta 2, 2 lungs. Okay, this one is only going to act on beta 1, so it is great for the heart. It is going to lower our heart rate. Therefore, we must assess heart rate before giving this medication at the apical pulse. Hold if it is less than 60. All right, we must taper this med because we want to avoid rebound hypertension. We also have different types of beta blockers. Remember your OLOLs. So remember, acebutolol and propranolol are non-selective. So they're going to work on beta 1 and beta 2. They're going to work on the heart, which is good, but they're going to work on the lungs. Think 2 lungs. If your patient has COPD or is an asthmatic, they must be put on metoprolol, not propranolol and not acebutolol. Okay. We also hold for systolic blood pressure less than 100. Up next, we have atropine. This is what we give for bradycardia. If your heart rate is 30, we're going to stick you with some atropine, okay? This is going to stop the rest and digest phase. Therefore, we're going to switch from rest and digest to fight or flight. Fortunately, it is an anticholinergic drug. Anticholinergic drugs will dry you up. Therefore, if you're on any anticholinergic or a drug has anticholinergic effects, we provide patient education on these dries. That is, can't see, can't pee, can't spit, and pardon my French, can't shit. Okay, that's a way you can learn your anticholinergic dries, and you will memorize them. You will memorize the nursing interventions. Okay, we are going to suck on ice chips. We're going to chew sugar-free gum and sugar-free candy. Okay, we're going to increase fluids, fibers, fruits to help with that constipation, etc. We talked a little bit, Tampa talked a little bit about eye medications. A drying drug is contraindicated in glaucoma. With glaucoma, we've got issues with fluid in the eye. Therefore, we're not going to dry these patients up. Okay? Please, please, please monitor your urinary output. That your atropine is like your hallmark anticholinergic drug. Up next, we're going to talk about neuro. So drugs for seizures, Parkinson's, Alzheimer's, and psych. Okay? Up first is our phenytoin, our dilantin, very good for seizures. Unfortunately, this has a very narrow therapeutic window, 10 to 20. Additionally, this can cause gingival hyperplasia and drowsiness. Note, lots of our seizure meds are going to make them very drowsy, so they shouldn't be making any crazy decisions or driving vehicles. Up next, we have our valproic acid. We're really going to focus on the adverse effects, meaning this can prolong your bleeding time. Please monitor your platelets and please monitor your clotting time. It's got to, again, a lot of your seizure drugs have narrow therapeutic indexes. The reason we do this is because, again, it's very hepatotoxic, toxic to your liver, and it can mess with your platelets. If we become toxic, my liver's going to tank and I'm going to bleed out, okay? So we're also watching for bleeds. Up next, we have rivastigmine. What rivastigmine does is it prevents the breakdown of acetylcholine, making it a very, very great drug for Alzheimer's. Remember, Alzheimer's, we've got some issues with acetylcholine, and we've got issues with some dopamine as well. Unfortunately, with rivastigmine, it, again, has your anticholinergic dries. We've already talked about our anticholinergic dries. No need to kind of reiterate that. Therefore, our nursing interventions, remember your Alzheimer's, these patients wander, so watch your patients and teach them about the anticholinergic dries. Okay, this drug can cause bradycardia. Please, please, please watch the heart rate. Up next, we have carbidopa and levodopa, a very good drug for Parkinson's. This is synthetic dopamine. We know that with Parkinson's disease, we have too little dopamine, too much acetylcholine. So carbidopa, levodopa is going to effectively, because it's a combo drug, effectively cross the blood-brain barrier to give more dopamine to help with the Parkinson's symptoms. Okay, we talked about Parkinson's and Complex Health 1. If you want to go review that, you can. But some of our big side effects are going to be orthostatic hypotension and telling the patient it can turn your urine and sweat brown, but please tell your patient, eat low protein. We have to eat low protein because a high protein diet is going to make the levodopa and carbidopa ineffective. So low protein, low protein with levodopa. Here are some of the common side effects. We're going to now begin the antipsychotic portion of things. So just keep in mind, these are the most common side effects of psych drugs. We have our pseudo-Parkinsonism, which is Parkinsonism-like symptoms, but the patient doesn't have Parkinson's. They just look like they do. We have our akathisia. I want you to think more feet and walking and movement. That's your akathisia. Your acute dystonia will see more kind of eye issues, more neck, head issues. And with tardive dyskinesia, I want you to think T for tongue and mouth. You'll see more mouth symptoms. You'll see more smacking, tongue rolling, chewing, more face stuff. With the acute dystonia, we'll kind of see more head jerky movements, eye jerky movements. That's a good way you can kind of make the connections. Up first is our Haldol. This is a typical antipsychotic. Remember, with our typical antipsychotics, we're concerned for what is neuroleptic malignant syndrome, okay? Haldol, because it is a typical antipsychotic, it will only treat the positive symptoms of schizophrenia, meaning the above personality. This is a sedating drug, so we have to make sure that we're not using alcohol with this. We're not using other CNS depressants, and we're monitoring respiratory rate. If you are on a depressing medication, think respiratory medication. I don't mean depressing like for depression. If it is a sedating med, it is going to cause respiratory depression amongst other things. Okay, so please keep that in mind. Up next, we have our atypical antipsychotic. Atypical antipsychotics will treat both the positive and negative symptoms of schizophrenia. So they will treat the positive, the above the personality, the weird, wacky, crazy, while also treating those low symptoms of isolation and depression. Okay, because it's second generation, they're less likely to have more severe side effects. Okay. Really, we are teaching them to practice safe sun with this photosensitivity, and it does have some anticholinergic effects, blurred vision, and as always, if you're on an antipsychotic, please assess your patient for extrapyramidal symptoms, tardive dyskinesia, all of what was on the slide before. Up next, we have lorazepam. It is a benzo, meaning a sedative, okay? What I want you guys to think about when we're thinking big picture for psych medications, it kind of goes hand in hand with nursing priorities. Okay, yes, we care about patient education. Yes, we care about a lot, but what does NCLEX care about? What does NCLEX test you on? It tests you on safety. So this is a sedative hypnotic drug. Therefore, with overdose, it can cause respiratory depression and respiratory arrest. So please monitor your patient's respiratory rate. We must get the rate before giving the drug, and we must monitor the rate after getting the drug. In the event that your patient's respiratory rate is 6, we're not going to give Narcan. Narcan is used for opioid overdose. This is a benzodiazepine. Therefore, we are going to give flumanazole. If it's a benzodiazepine, we give flumanazole. A good mnemonic is you flew fast in your Mercedes Benz. Okay? Flumanazole for a benzo overdose. Okay? Also, please don't abruptly stop this medication. We must taper it. Also, it's a sedating med. No driving, you're not deciding to get married, you're not doing your tax forms, you're not doing anything that requires a lot of thinking, okay? Up next, we have our TCAs, tricyclic antidepressants. Really, these medications are not safe. They're rarely used. Because they're so unsafe, you have a very big risk for serotonin syndrome, for overdose on these meds. They're not safe. Therefore, what I want you to understand is we need a 2-week vacation on TCAs. If you're on a TCA, you cannot be on any other psych meds. No SSRIs, no MAOIs, no SNRIs. TCAs, take alone. Get it? Take T alone. A TCA, take it alone. That's how I like to remember it. It also does have both sedating and anticholinergic effects. Up next, we have our SSRIs, fluoxetine. These are your selective serotonin reuptake inhibitors. A lot of people are pretty familiar with these. Again, our big nursing consideration, if it's going to increase serotonin levels, too much of a good thing is not a good thing. We're looking for serotonin syndrome. That is an overdose on serotonin. What will you see? You'll see mental status changes, tachycardia, tight muscles. Think wet dog shakes. You're shaking, you're tensed up, you're sweating, and you are panting. Wet dog shakes. These do take a little bit of time, so you're not going to get anything right away. Up next, we have our SNRIs. Again, similar consideration. We're looking for serotonin syndrome, okay? That is our big picture for both SSRIs and SNRIs. Specifically with your SNRIs, please monitor your sodium levels, okay? Alteration, because this can cause hyponatremia. So the SNRIs, N, think Na, sodium. So our nursing interventions, we're going to watch for serotonin syndrome. We're going to monitor sodium levels, okay? And like I said with the SSRIs, you shouldn't be on multiple antidepressants. It's not safe because of this risk for serotonin syndrome, okay? Another photo of our serotonin syndrome, aka our wet dog shakes. Up next, we have our MAOIs. These are no popular meds. Nardil, Parnate, Marplan. Not important to know the names, but just note that MAOIs can cause a hypertensive crisis. Very, very scary. We also must take MAOIs alone with no other psych meds. So that's our second bullet point. And our third bullet point kind of goes hand in hand with the hypertensive crisis. If you have tyramine foods, meaning our charcuterie boards, yogurts, wines, caffeine, aged meats, wines, deli cheeses, pickles, all of that will cause you to have a hypertensive crisis. And again, that's not good, okay? That's what I want you. Again, we're kind of following. I know I ramble a bit, but we're really honing in on those three most important things, those 3 bullet points, okay? 3 big picture stuff. Up next is lithium, only drug that is used to treat bipolar. A couple things we got to do with lithium. We must keep it within therapeutic range, okay? We need it no greater than 2, but ideally we want it between 0.5 and 1.2. Signs and symptoms of toxicity will include ataxia, tinnitus, dysrhythmias, seizures, confusions, just odd symptoms that we shouldn't be seeing in a healthy individual. The reason I want you to also note sodium. We must be watching sodium levels. If the patient has hyponatremia or instances of dehydration where they've lost a lot of salt because they were running and sweating a lot, this will worsen lithium toxicity. Why? Just look at your periodic table. Look where they're located, okay? They're similar to sodium and potassium, how they're kind of enemy-like, if you will. So watch your patient's sodium on this drug. Lots of patients do report a metallic taste and some vomiting with this medication. Okay. Up next, we have Haldol. This medication, again, typical antipsychotic. When you think typical, this will this will only treat positive medications. I believe we've already talked about this one, but just to reiterate, watch for that extrapyramidal symptoms and watch for sedation. Okay. Up next, we have our Artane. Okay, we've got Artane. Artane is used again. It's another drug that will help treat Parkinson's disease. Remember, we've got this imbalance. We've got way too much acetylcholine, okay? So we're going to try to block acetylcholine. Therefore, we're going to have that anticholinergic drive. So we're not going to give it to our patient with glaucoma. If our patient has a GI or GU disorder, we're also not going to give it to them. Why? We know they can't pee and they can't poop with this drug. So again, that's just something we've got to be thinking about. But again, take it back to your anticholinergic dries. If you know, and people ask me, well, Tiffany, there's so many different drugs for Parkinson's. How do I know what drug is for Parkinson's? Well, think of the path of Parkinson's. Too little dopamine, too much acetylcholine. So if you have a drug that is an anticholinergic, it's probably either A, going to be used for its anticholinergic dry effects, such as some pre-op prep, or it's going to be used for Parkinson's, because with Parkinson's, we're trying to get rid of acetylcholine. So we're going to give an anticholinergic. That's why it's important. If you have a massive brain fart on an exam, try to remember your path, though. All right, up next is our cardiac drugs, everybody's favorite drug. So I kind of have this little diagram broken up for you guys. It really helps us kind of, okay, what's for what are we going to do? I like to use the A, B, C, D, D, E method. That helps us kind of, you have your ACE inhibitors, ARBs, beta blockers, calcium channel blockers, digoxin, and diuretics, okay? And the E stands for EKG, but it's not really a drug. So let's begin. Up first, we're going to talk about digoxin. This helps improves contractility of the heart. It's going to help with squeezing. However, we must be aware of the narrow therapeutic range, 0.8 to 2. This will put you at risk for dig toxicity. Your patient will start having nausea, vomiting, very bad headache, blurry vision. You know it's getting bad when they start having halos and they start throwing PVCs. So mental status assessments, cardiac assessments. We also need to make sure that, again, with most of our cardiac meds, hold if the heart rate's less than 60, hold if the heart rate's less than 100. Hypokalemia will worsen dig toxicity, so please make sure you're eating your leafy greens. Our antidote's pretty easy to know. It's just dig immune fob. Up next, we have nitro. We all know good old-fashioned nitro, sublingual drug. Take 1 every 5 minutes under the tongue for chest pain, angina. Max out at 3. If you've taken 3 and it's not working for you, please call 911. It's very important that we tell this patient it can cause a very bad headache, so sit down. I was telling someone earlier about some American Red Cross stuff I did today. I was telling my fellow colleagues, I said, we've got one problem. If someone's having a heart attack, that's one problem. It's a bad problem. We don't want it. But guess what happens when they pass out and they fall on the floor and they crack their head open? Now we have 2 problems. We don't want more than one problem. So tell them to sit down, okay? Also contraindicated in our ED pills. We talked about that earlier. Now we get to talk about our fun diuretics. Diuretics get fluid off. There's about 4 different types of diuretics. 3 are for the heart, 1 isn't. We'll talk about it. But up first is our thiazide diuretic. Okay, it's very important for all diuretics. We're going to use thiazides as our diuretic prototype, meaning we're doing daily ways. Like when you think diuretic, think thiazide diuretic. We are doing daily ways, strict INOs. We are doing their vitals. We are assessing for edema. We are doing all the things. Okay. Just one special thing about thiazide diuretics, we don't see them used too often because a lot of people do have allergies. So just note, if you do have a sulfa allergy, this drug's probably not for you. But I would focus more on your general diuretic considerations. Up next, we have loop diuretic or Lasix diuretic. This one is more common, okay? This is going to get everything off. It's going to get sodium off. It's going to get potassium off. It is going to get water off. It's going to get calcium off. It's going to get everything off, and that is really, really great. Not only will it reduce hypertension, but Lasix specifically are very, very safe on the kidneys. They're one of the only drugs that are preferred for renal patients. That's why we usually see most of your renal patients require a diuretic. That's why Lasix is very, very common. However, this can cause some ototoxicity, so watch your ears. Remember, we know that this drug helps get rid of potassium. If your patient is on digoxin, we know hypokalemia worsens digitoxicity. So it's all related. It's all a big cardiac circle. All right, up next we have spironolactone. I just want you guys to know it's potassium sparing. It will not get potassium off. So this is usually what you'll give a patient if they're on digoxin, okay? Or you'll give it to a patient that's just pretty hypokalemic on other meds. It's important to note, though, this won't get potassium off. So we're going to teach our patient, you're still going to have to restrict potassium, okay, because this won't get that off. We also teach our patients to take their diuretics in the morning because we don't want them getting up at night peeing all night, okay? It's just important to note, again, your basic diuretic considerations, but what makes each diuretic different? Well, thiazides are contraindicated in sulfa allergies. Your Lasix is pretty safe on the kidneys, but it can mess with your hearing. And your spironolactone, it's not going to get rid of potassium. So that's how you can understand, okay, what do diuretics do? What are the basic considerations of all diuretics, and what makes each diuretic different? Up next, we have mannitol. Again, it's a diuretic. It's going to get fluid off, but what's specific about mannitol is it specifically helps relieve increased intracranial pressure. So it's great for patients that have a traumatic brain injury or a possible brain tumor, things like that. Because remember, we got fluid in the brain, and one of the first things that displaces when we have increased ICP is going to be that fluid. Mannitol helps get the fluid off. However, it's not very safe for patients with cardiac issues. That's why we only use mannitol for really brain purposes, because most patients that require a diuretic have some sort of cardiac issue. Well, this drug isn't safe for cardiac issues such as congestive heart failure. But remember, if you go back to the path of congestive heart failure, they rock the body with fluid, so they need help getting fluid off. So if your patient does have congestive heart failure, we're going to opt for something else. So in a nutshell, mannitol, great for the brain, terrible for the heart. We're doing frequent heart and brain assessments. This is now, again, same slide, metoprolol. We've already talked about it. Up next, we have clonidine. Okay, again, with clonidine, it's also known as Catapress. However, I like to say the 3 Ds with clonidine: dry mouth, dizziness, and fatigue. Okay, usually comes in the form of patches that can be worn for 1 week. Again, most of our cardiac meds we do need to taper. This med is very hepatotoxic. Up next, we have our ACE inhibitors. They will always end in pril. When you think ACE, I want you to think ACE, angioedema, dry cough, and elevated potassium. Okay. Therefore, again, back to that cardiac circle of meds, if your patient requires a diuretic and is on an ACE inhibitor, we're probably going to put them on a thiazide or loop diuretic because we're trying to not have really high potassium. We know that this drug will elevate your potassium. So frequent cardiac assessments. What's nice about ACE inhibitors, they only work on the blood pressure arena of things. So you don't need to check the heart rate before giving. You just need to check the blood pressure before giving. Most patients will complain of the side effect of a dry cough. Not to worry, if they do have a very severe cough, we will replace it with an ARB, angiotensin blocker. They do the same thing, they're just better tolerated. Your ARBs will end in sartan. Okay. This medication now enlists the help of sodium. It's going to kind of promote excretion by getting rid of some sodium and some water. But what do we know? My other slide said salty bananas. They hate each other. You don't put salt on a banana. That's gross. Okay. That's a mnemonic I like to tell my students. If you have too much salt, you're going to have too little potassium. If you have too much potassium, it's going to throw your salt off. Okay. They're opposites. Go back to our friend, the periodic table. Okay. Therefore, this medication will deplete sodium, so it can cause hyponatremia, which thus causes hyperkalemia. Anyway, don't worry about too much of the digitoxicity. That was from another slide, so please don't stress about that. I put the wrong nursing consideration for that, so please, please, please don't worry. Up next, we have our diltiazem, which is our calcium channel blocker. These are our very nice drugs: verapamil, nifedipine, and diltiazem. Those are all calcium channel blockers. You can further separate them into non-dihydrophene and dihydrophene. I wouldn't stress knowing that for the final exam. It should be pretty darn big picture. They're very, very good at treating rapid heart rates and hypertension. However, absolute contraindication is grapefruit juice. Think about it: milk and grapefruit juice. You wouldn't drink the two beverages together. That would be weird. That's how you know no grapefruit juice with the calcium channel blocker. As always, we're assessing heart rate and blood pressure before giving. If you overdose on a calcium channel blocker, we give them milk. Okay, we give them calcium. All right, hit the points that I needed to hit. Now we get to move on to our hematological drugs. Specifically, what I want you guys to remember are the labs we must monitor and the antidotes for each. Starting with heparin. Heparin works right away, often used as the bridge to warfarin, short-term, quick onset. It can put you at risk for bleeds. It's an anticoagulant. We must watch both our platelets and our APTT. If you were to look at my APTT, I am not on heparin. My APTT would be 30 to 40. However, if my patient requires heparin, I want their APTT to be 47 and 70. This tells me that heparin is working. So please remember the therapeutic range for heparin. All right. Also remember the antidote for heparin. You will get this on boards. You will get this on practice ATIs. You will get this all the time. It will never leave. Do not pump and dump this information. The antidote is protamine sulfate. And as always, if you're on an anticoagulant or antiplatelet, please watch for bleeds, ataxia, which is a bloody nose, petechial rash, bruising, etc. All right. Up next, we have Lovenox, which is just low molecular weight heparin. It is safe heparin, so we do not need to monitor APTT, but we are going to look at the platelets, okay? Hold if the platelet is less than 1,000. This is usually given through subcutaneous injection in the stomach. Again, it's still heparin, but it is safe heparin. Up next, we have warfarin. Warfarin is what we send the patient home on, but remember, it takes about 3-ish days to start working. On heparin, though, we are going to monitor on warfarin, we are going to monitor the INR. Think WAR, W-A-R, think INR. I know a lot of students get confused. Is warfarin APTT, or is it INR, or is it platelet? Think WAR, INR. All right. The antidote for warfarin is vitamin K. Therefore, if your patient is on warfarin, we do not want them eating kale salads or eating foods high in vitamin K because it is going to negate the effects of warfarin. So yeah. Remember your therapeutic ranges. Up next, we have our aspirin, also known as ASA. It just helps make your platelets slippery so they can slide past each other. For patients that have atherosclerosis or an MI or a stroke, this is going to help promote blood flow. However, we are very concerned about salicylate poisoning, okay? You can overdose on aspirin. Really, we don't give children aspirin. Why? Reyes phenomenon, okay? We also have to make sure, this is more of a GI consideration, but if you're taking an antacid, no drugs within antacid time, if you will. With aspirin, because it's an antiplatelet, we're going to monitor the platelet counts. If it dips below 100, we got to call the provider. Does take time to work. This won't impact clotting, but it'll make your platelets slippery, okay? All right, up next we have clopidogrel, also known as Plavix. very good drug for stroke, given for patients with AFib. Unfortunately, these patients, this can cause, in addition to that prolonged bleeding time, it can cause some neutropenia. For clopidogrel, please tell the patient to monitor for signs and symptoms of infection. Up next, we have Alteplase, also known as ATP. This is a thrombolytic. This is a clot buster given within 3 hours of the onset of stroke symptoms, and we've diagnosed them with a stroke. It is absolutely contraindicated in bleeds, okay? If your patient is hypertensive or is bleeding anywhere, we cannot give this drug. It is a clot buster. If you have a cut anywhere or you have an injury anywhere, the body is fixing itself with a clot. Well, you're going to not only disrupt the clot in the brain that is the stroke, you're going to disrupt a clot somewhere else and the patient will bleed out. So just remember that with ATP. It's a clot buster, but it's contraindicated in bleeds. For our cholesterol meds, our hallmark cholesterol med is going to be your statin. So regardless of what cholesterol med we're talking about, we are going to look at their LDL, their HDL, and their triglycerides, okay? For your atorvastatin, it can be, usually the symptoms are mild, but I want you guys to be looking out for rhabdomyolysis. A patient with rhabdomyolysis, essentially their muscle is being broken down. They will start to have maybe red blood cells in their urine. They will have fatigue, malaise. They'll feel very tired. Those are early indications of rhabdo that we need to be looking for. All right. If they start to have tender muscles and weakness, they must call the provider. Additionally, kind of with that rhabdo, it can cause them some eye issues as well. Again, contraindicated in grapefruit juice. So now we get to talk about pain, inflammation, and gout. We're really going to focus on some of the side effects and patient teaching, but I also want you guys to understand what meds we give for what. If your patient has pain rated 2 out of 10, we can probably give them some ibuprofen. If it's maybe at a 6, we can give them some morphine. But if it's 10 out of 10 and they just had open heart surgery, fentanyl might be preferred. So just kind of know kind of the pain. That's why it's important we always assess for pain first. No matter what pain med we're on, we've got to assess pain. How bad is it? Where is it? This will dictate what medication we give. So up first is aspirin. I know that there's a lot of information on this slide. For our 3 bullet points, please note that this can cause a GI bleed. Why? Because it is COX-1 and COX-2. While it is inhibiting the inflammatory process, because it's also inhibiting COX-1, it's going to inhibit protective stomach lining. Therefore, you are at risk for GI bleed. We also need to monitor for salicylate toxicity. We will see that with a salicylate level over 30. You'll start to see some neurocognitive issues, ringing in the ears, confusion, etc. If it gets over 50, your patient is going to have a very bad cardiac event. Okay? Therefore, you shouldn't be taking multiple NSAIDs and avoid salicylate foods. That's kind of your salicylate poisoning bullet point. And then I would just note the thrombocytopenia. So we're really looking at platelet counts. Up next for ibuprofen, again, COX-1 and COX-2, so it can cause some inflammation. However, remember, we talk about the kidneys a lot and the liver a lot. And 2 things that really do, unfortunately, wreck those organ systems is NSAIDs and pain meds and your antibiotics, okay? The one thing about ibuprofen, because see, we talked about aspirin. Aspirin is used for fever, inflammation, and some platelet stuff. So for a lot of patients that have history of MI, they'll be put on some aspirin, like a baby aspirin. Ibuprofen, on the other hand, while it is also an anti-inflammatory, it has nothing to do with platelet aggregation, whereas aspirin did. Ibuprofen essentially does the same thing, has the same risks, except that bleed, okay? So very similar drugs. Up next, we have Saloxib. Because Saloxib is only a COX-2 inhibitor, it's very good at pain and inflammation. It puts you at significantly less risk for a GI bleed. So I would just note that this is a little bit safer. We're still going to report signs and symptoms of a GI bleed because all of our NSAIDs do cause general GI upset. So just keep that in mind. Saloxib is just safer, okay? Up next, we have prednisone and betamethasone, very good anti-inflammatories. You'll see this used a lot in patients with autoimmune inflammatory disorders such as rheumatoid arthritis, SLE, multiple sclerosis, things like that. Why? Our own physiological anti-inflammatory process is part of our immune system. So if you're on an oral corticosteroid, you're gonna, in one way or another, be immunosuppressed. So we got to teach about that infection prevention. Additionally, I want you guys to note Cushing's syndrome, very important for steroids. With our inhaled corticosteroids, which we'll talk about in respiratory, we're more concerned for obviously Cushing's, but oral thrush. But for these oral corticosteroids, please focus on Cushing's, especially with long-term use. We have hypertension, hyperglycemia, truncal obesity, buffalo moon hump. So I would remember Cushing's, risk for infection, anti-inflammatory. And you must taper. You must taper your steroids. Now we get to talk about anti-gout meds. We talk about gout and complex health 1. Well, these are the meds associated. Remember, gout is from increased uric acid production. Up first, we have allopurinol. Please think all the time you take allopurinol all the time. This is a good gout prophylaxis. It's going to prevent the formation of uric acid. However, it is contraindicated with thiazide diuretics, okay? Also get frequent vision checks. However, there is no drug that fixes everything. So if your patient is on allopurinol, we're still going to provide patient education on avoiding organ meats, foods that are very high in purines, which would be your organ meats, gravy, liver, beer, caffeine, all of it. And finally, drink water. It's going to help flush everything out. Up next is colchicine. This is what we use for a gout attack. So when someone's having a painy gout attack, we give colchicine. This is not to be used every day. It's used for attacks. However, this can cause 2 very bad side effects, agranulocytosis, so please watch your CBCs. This can also cause rhabdo. We've already discussed rhabdo, so please report general malaise, muscle weakness, changes in the color of your urine. Up next, we have acetaminophen, also known as Tylenol. So please be aware that Tylenol does not do anything for inflammation. If I sprain my ankle and I have a lot of inflammation and pain, we're going to opt for ibuprofen. For acetaminophen, all it does is it treats pain and fever. It's not an anti-inflammatory. This drug is very nephrotoxic and hepatotoxic. Max dose is 4 grams a day. If we overdose, we'll have a lot of GI symptoms, and we give the antidote N-acetylcysteine. Morphine, this is for some severe pain, okay? A big issue with morphine is it can cause respiratory depression. So we're monitoring the respiratory rate and their oxygen O2 sats. Okay, very, very important. Because morphine can cause both respiratory depression and mild sedation, if your patient was a car accident patient and you suspect a TBI or a concussion, we cannot give them morphine because of its sedating effects. This will mask manifestations of increased ICP, Cushing's triad. Remember, just respiratory depression and sedation are very important, and there's many nursing considerations associated with that. In the event that we overdose my patient on morphine and they had a respiratory rate of 4, we give them Narcan, okay? However, it's got some pretty nasty side effects. Sweating, they'll rapidly have pain because we've gotten rid of the morphine in their body that's being used, things like that. Most often in the field, people, if they suspect an overdose, they'll give Narcan. If it doesn't work, we know that they have overdosed on something else. So again, it's usually used for treating opioid withdrawals, but it also helps us kind of further narrow down what someone might have overdosed on. So now we get to talk about antibiotics. Really, we're going to focus on the main adverse effects, nursing interventions, and nursing patient education. There's quite a few antibiotics, but St. Pete, if we're following your blueprint, there's 7 questions on antibiotics. There's about 7 antibiotics on your list and in this PowerPoint. So really, what's the main takeaway of each antibiotic? We don't really care about what it's used for. It's an antibiotic. It's used for an infection. With our penicillins, I want us to think this is the prototype of antibiotics. We are going to get a culture and sensitivity first. We are going to assess for allergies. We are going to tell our patient, you must take all of your drugs. We're going to tell our patient, watch for superinfection. This can be like a yeast infection. It can be like a oral infection, things like that. One thing specifically about penicillins is that they can actually lower your blood cell count. So just keep that in mind. And again, penicillin, think prototype, antibiotic prototype, very, very, very nephrotoxic. Specifically about penicillins, we're about to move on to cephalosporins, but if you have a penicillin allergy, you probably have a cephalosporin allergy as well. Okay, when we think Ceph the giant, okay? GI upset, increased blood glucose levels, anaphylaxis, nephrotoxicity, and thrombocytopenia. Okay, these are our main side effects. In addition, that was kind of like our first bullet point for cephalosporins. Our second bullet point is going to be no alcohol when using Ceph. It can cause a disulfiram-like reaction. Essentially, what do you look like when you get really, really, really drunk? Flushing, dizzy, headache, your tummy hurts, your tummy's cramping, probably gonna vomit soon. So yeah, just keep that in mind. That's really, I think, the 2 important things. And we've already talked about the penicillin allergies. Up next, we have our macrolides. These usually end in mycin, your azithromycin. The only mycin that isn't a macrolide is Vanco. Vanco is its own special thing. Okay, Vanco is a fun drug. But for our macrolides that will end in mycin, I really want us to note that this can cause arrhythmias. You should not be on multiple macrolides. So we must be watching for EKG changes. Additionally, warfarin interacts with macrolides. So that's just something we kind of got to be aware of, but I would more focus on some of your cardiac considerations. But again, note the cardiac considerations, but at the end of the day, what are our basic antibiotic interventions? Vanco, again, Vanco, I love to teach about Vanco because it does things no other drug does. It causes red man syndrome. This happens when we give it too quickly. If this occurs, we must stop and slow the infusion. This can cause severe hypotension, tachycardia, and red blotching. The way we prevent red man syndrome is by giving this drug slowly and thoroughly administering or thoroughly checking peaks and troughs. Also check your hearing. And general rule of thumb, if they're on a heavy hitting antibiotic, we want to avoid alcohol. Not only will it cause a disulfiram-like reaction, but these drugs are harsh on the kidneys and the liver. Alcohol is harsh on the kidneys and the liver. Just good rule of thumb. Up next, we have our tetracyclines. Really, I want us to note that with our doxycycline and our tetracyclines, they're not safe for children. The reason, think tetracycline, think teeth. It is going to impact your teeth and your bones. It's also will cause photosensitivity, so practice safe sun, meaning wear your long brimmed hat, wear your sunscreen, stay out of the sun, okay, because they will burn, okay? But really focus on the fact it's not safe for kids or pregnant women because it will cause teeth discoloration, bone development issues, all of that stuff, okay? Also, no, I think that's all I want. That's all I want you guys to focus on, okay? Up next, we have gentamicin. Gentamicin, I like to call this one the 3 blind mice, okay? It's got 3 bad side effects. It can be ototoxic, nephrotoxic, and neurotoxic. How do we check for ototoxicity? Is your patient all of a sudden having a hard time hearing you? Are they reporting hearing weird things? Nephrotoxic, BUN and creatinine, changes in urinary output, changes in urine color. Neurotoxic, remember our respiratory control centers in the brain. Look at your respiratory rate, okay? That's what we're going to do. We're going to look at those 3 blind mice side effects, and we're going to teach the patient what they need to monitor, and we're also going to monitor those things as well. Very therapeutic, very narrow therapeutic index. If anything has a low therapeutic index, it probably has pretty severe side effects, and we need to be doing peaks and troughs. Up next, we have sulfonamines, all sulfa drugs. I want you guys to note that sulfa drugs are most often used for UTIs. That will just help you in your UTI portion of the complex sulfa 1 exam. But for pharmacology purposes, we're going to focus on the facts that sulfa drugs can crystallize and clump in the kidneys. They can also cause some irritation when you go to the restroom. Okay, in order to prevent this, we are going to tell our patient to drink lots and lots and lots and lots of water. Okay, also think of your sulfa sunburn, practice safe sun. Up next, we have our fluoroquins. Think tendon close to the floor. These can cause a tendon rupture, and it can also cause some cardiac issues. Specifically, though, we're going to teach our patients to watch and report any wrist, foot, or joint pain. Okay, this drug, they also need to drink lots of water because this also can cause irritation when you're using the restroom. But I focus more on the risk for tendon rupture. If all of a sudden your patient's like, man, I think I sprained my ankle, or man, my shoulder really hurts, call the provider. They probably ruptured their tendon. Moving on from antibiotics, we are going to talk about tuberculosis drugs. Remember, with our tuberculosis, we use the RIPE method, rifampin, isoniazid, pyrazinamide, and ethambutol. General nursing considerations for TB meds are going to be watch your liver function. They're very harsh on the liver. So if a drug is very harsh on the liver, we don't want them to consume anything that also will hurt their liver, like alcohol. We also must stress the importance of 90% adherence. They must take their drugs 90% of the time in order to get those 3 negative sputum cultures, okay? Very important. So those are just general TB considerations. Now, what makes each TB drug unique? With isoniazid, I want you to think peripheral neuropathy. It can cause peripheral neuropathy. So do feet checks. Like, when you go to palpate their pedal pulse, when you go to palpate their post-tibial pulse, ask them, can you feel this? Can they push on your hands? Can they feel what you're doing? Are they having difficulties picking up their water bottle because they're having a difficult time feeling? That's peripheral neuropathy. So something that they can do to help prevent peripheral neuropathy is going to increase their intake of vitamin B6. That's what makes isoniazid unique. Think vitamin. Up next is ethambutol. Think E for ice. This can cause optic neuritis, so teach these patients to get frequent eye exams. Up next, we have rifampin. Think ripe like an orange. It can cause your body secretions to turn orange. So yes, we're going to educate them on general TB drug considerations, but also when they throw in a drug such as rifampin, you gotta know what makes rifampin different. Okay. And finally, we have pyrazinamide. I want you to think photosensitivity and worsens gout. Okay. Why does it worsen gout? Pyrazinamide produces uric acid. We're also going to teach our patient to drink lots of water to help kind of combat this issue. Okay. All right. Up next, we have our antifungal drugs. So fluconazole, very good antifungal drug. Okay. What we're more concerned about with fluconazole, these are your azoles. They cause photosensitivity and hypokalemia, contraindicated in grapefruit juice. Tampa, you might have the drug amphotericin B. While amphotericin B also has these similar side effects, we know that patients usually have very bad allergies to amphotericin B, so we're going to pre-treat amphotericin B with Benadryl, diphenhydramine. Okay, I'm just trying to help you guys out a little bit. So now we get to talk about our super fun GI drugs. Really, we're going to focus on some of the main nursing considerations, and when we get to ulcer drugs, more the mechanism of action. So up first is promethazine. This is really good for nausea and vomiting, but again, anticholinergic drugs. Also, it could cause extrapyramidal symptoms, so watch them for irregular movements, whether it be irregular feet movements, irregular head movements, irregular mouth movements. Those are your extrapyramidal symptoms. Also, what's interesting about promethazine is that it can turn your urine a reddish brown and alter the color of your stool. Up next is Zofran, generally very well tolerated drug, antiemetic drug. However, we must be careful with respiratory depression. This drug can cause some respiratory depression, so we're not going to give it with other drugs such as opioids that would also cause respiratory depression. With our GI antiemetics, we're going to do full GI assessments, assess for nausea, vomiting. Is it working? Is it not working? Listen to bowel sounds. A big issue with vomiting is dehydration, fluid, and electrolyte loss. Okay. So kind of assess for that too. Up next, we have metoclopramide. This is, again, a pro-motility drug, so it's going to help move things along. And that's why it's really good drug for GERD, because it's going to help move food from the stomach to the intestines pretty quickly. We know that with GERD, food stays in the stomach and it gets refluxed back up. So this is going to help speed things along. However, this can cause neuroleptic malignant syndrome. Therefore, we must be looking at the heart rate, rhythm, and levels of consciousness. Again, we're going to take this before meals and remain upright. Generally, we shouldn't use it longer than 12 weeks. Up next, we have milk of mag, really good drug for constipation, helps with GERD as well. However, think about it, milk of mag, it has, it's got magnesium in it. And therefore, what issues would we not want a patient? What issues would warrant? I'm so sorry. What chronic conditions would we be concerned about when determining whether or not to give a patient milk of mag? Well, we talk a lot about kidney patients. They have a buildup of everything: magnesium, calcium, all of the above. So if your patient has a renal issue, we really don't want to be giving them milk of mag, because when magnesium builds up, it can cause some heart block. So you've learned a lot about it in your Women, Children, Family lecture, but patients with mag toxicity, it depresses them, not mentally, but they'll have decreased reflexes, they'll have heart block, they will have confusion and muscle weakness. So you can overdose on magnesium. It is not safe. Therefore, not for long-term use. Up next is stimulant laxative, Biscadil. Does take a little bit of time to work, but we should never use this drug long-term because it can promote chronic constipation, because it'll decrease the tone and sensation. Please be aware we should not be using this in severe cardiovascular disease. And as always, I know we're we can get a little discouraged when we're trying to figure out, well, what do I have to memorize for each medication? There are some little things, but as we kind of get into the GI portion of things, a lot of it begins to overlap. Doing your GI assessments, providing patient education, things like that. Up next, we have Metamucil, the only constipation drug that's safe for daytime use. But with Metamucil, we must have fluids. If not, it can cause an intestinal obstruction. So drink water before and after this medication. How do we monitor for a GI obstruction? Patient usually will complain of pain, but we will hear hyperactive bowel sounds above the obstruction, and we won't hear anything below the obstruction. Up next, we have Docusate, Colace, good drug for constipation, but it uses water to work. So we have to make sure that the patient drinks water. If they don't drink water, it is not going to work. All right, so now we have our anti-ulcer drugs. For anti-ulcer drugs, it's recommended to know the mechanism of action, some patient teaching, and nursing considerations. So famotidine, these are your H2 blockers. They end in tidine. Okay, this will decrease secretion of acid. So it does not neutralize acid. It decreases production. We know that with GERD and reflux, we reflux acid. So our goal is to produce less acid. However, please watch your blood cell counts, as it can cause neutropenia, thrombocytopenia, and agranulocytosis. Also, general anti-ulcer considerations: give it before meals, remain upright, and avoid trigger foods. Up next, we have our PPIs, proton pump inhibitors. They end in prazole. Again, this also acts with reducing the production of stomach acid, but this is a very good drug for H. pylori infections due to our combo therapy. If you have an H. pylori infection, you will do 2 antibiotics from a different class, each have to be from a different class, plus a proton pump inhibitor. It will end in prazole. Our big issue with prazoles, though, is they can cause decreased calcium absorption, which puts you at risk for osteoporosis and hip fracture. Therefore, not safe for long-term use, and we'll tell our patient increase calcium and B12. Up next, we have antacids. These neutralize your stomach acid. So anything that's going to impact stomach acid in one way or another must be taken by itself. This is because most drugs rely on the acid of the stomach to break it down and help with the absorption. But specifically with antacids, you must take it an hour before or after meds, sometimes 2 hours. It depends on what your professor tells you, because I know they're a little bit different. But essentially, you could have like your calcium carbonate. A big side effect of our aluminum antacids is it can cause constipation, but our mags can cause diarrhea. Well, think about it. Milk of mag, it's a laxative. So that's kind of how you can help with that. Also, drink lots of water. Up next, we have everybody's favorite. We have respiratory drugs. I kind of have it split into upper respiratory drugs and lower respiratory drugs, but we will work through it together. Up first, we have diphenhydramine, also known as Benadryl. This is more used for that upper respiratory tract, for that runny nose, cough, itchy throat, things like that. What I want you to know about diphenhydramine, such as Benadryl, is it can have a very big sedating effect. In addition, a sedating effect and drowsy effect, in addition to anticholinergic dries. So no alcohol, no glaucoma. Please don't drive if you've taken a lot of Benadryl. Please don't overdose on Benadryl. That just happened. It was in the news a few days ago. Anyway, up next we have our nasal decongestants. These are usually nasal sprays. A big thing to know with our decongestants, they can cause some heart palpitations, but these are not safe for long-term use because they can cause rebound nasal congestion, meaning I've taken a decongestant for 2 weeks. I stopped taking it, and all of a sudden, I have the worst congested nose of my life. Therefore, we're not taking it longer than 5 days. The reason it's contraindicated with epinephrine and antihypertensives is because it impacts the heart, causing palpitations. Up next, we have antussives. These are cough suppressants. Really, not much to cough suppressants, I think. These are usually your cough syrups. They are in syrup form, so it's important to, again, do your respiratory assessment. But when we're giving this medication, we use a medication measuring spoon. We do not just chug it out of the bottle, or we don't use a spoon from home because we have no way of measuring. No MAOIs. Up next, we have our expectorants. These help us thin mucus so that we can cough it up. We know that especially with COPD patients, they have a hard time doing that. So this is usually a drug given for COPD patients. However, we must drink lots of water because that's how we're going to cough it up. So again, similar to how some of our drugs for constipation, you need to take it with water. Well, this expectorant, we need to take it with water or it's not going to work. Okay, it can make you a little bit drowsy. Make sure we're auscultating the lung fields to determine effectiveness. If you were given if you auscultated your patient's lungs and they were crackly and they sounded bad, well, let's give it a listen. Ideally, after using this drug, if we assess, a little while later, we should hear improved symptoms. Now we get to talk about our respiratory drugs for the lower respiratory tract. This is our SABA, short-acting beta agonist, meaning it doesn't last long, but it works quick. This is an emergency drug. We give this in emergency situations. If a patient's PEFR is in the red zone or someone is having an asthma attack, we give albuterol. However, because of its, albuterol has the fight or flight symptoms. Remember, bronchodilation, increased heart rate, pupil constriction, constipation, things like that. So while it will work in an emergency situation, we got to be aware that it will cause increased heart rate and blood pressure, which can cause some dysrhythmias, things like that, especially in kids. Speaking of kids, they probably will require a spacer if they have difficulties. Please review how to administer a inhaler. That is a big NCLEX piece. Essentially, you're going to remove the cap from your MDI, tell the patient to take a deep breath and exhale. Then you're going to insert the mouthpiece, close your lips tightly around the mouthpiece. Then while it's in your mouth, you exhale and then have them press the inhaler and then inhale. They should then hold their breath for 5 to 10 seconds, remove the MDI, and then exhale slowly. Please make sure they rinse their mouth after using this medication, as it can cause oral thrush. Your salmeterol is your long-acting beta agonist. Same rules apply. Just know that your salmeterol, because it's long-acting, you won't see high amounts of excitability, but it's not going to help in an emergency situation. Also, sorry to go back, but with your albuterol, we have to always give this medication first with emergencies. But let's say they have their albuterol and their Spiriva for like PRN. We're going to give the albuterol first because it's going to open up the airway so that the other drugs like methylxanthine can get to where they need to go. So methylxanthine is a caffeine derivative. So think of all your overdose on caffeine symptoms: tachycardia, palpitations, restlessness, possible seizures with an overdose. This is not a rescue drug. Keep in mind, we're kind of concerned about things being toxic. So just think of a caffeine overdose, toxicity. And then same rules apply, administering, things like that. Up next is cromolyn sodium. It's a mast cell stabilizer, helps with inflammation, specifically histamine. Similar to an antihistamine, it can have those same antihistamine sedating effects. What's interesting about this one is that we must taper to avoid a post-nasal drip, and this may cause a rebound bronchospasm. Beclomethasone, this is our inhaled corticosteroid. It is a corticosteroid. It's a steroid. Think Cushing's, okay? So we know our Cushing's considerations, but also with inhaled corticosteroids, we have to rinse our mouth after, specifically with like a nice satin swish and spit, especially if they get oral candidiasis from it. But please rinse your mouth. And last but not least, we have endocrine drugs, okay? Specifically our thyroid drugs and our anti-diabetic drugs. So up first, we have Synthroid, levothyroxine, sodium. This is a synthetic form of T4. Remember, our T3 and T4, they give us energy, okay? However, if we get too much of this med, we're going to have a lot of energy. So tachycardia, tremors, angina, insomnia, and heat tolerance. Very similar to the signs and symptoms of hyperthyroidism. Our main issue is that it can cause some big issues. In order to determine effectiveness, we monitor TSH levels. They should decrease while on this drug. Remember, if my body senses it needs T3 and T4, it's going to increase the amount of thyroid stimulating hormone because that is triggering my body to produce more T3 and T4. But if I have enough T3 and T4, my thyroid stimulating hormones levels should decrease and become normal. Okay, it's very important we do take our pulse before giving this drug. If your patient's heart rate is 110, probably not the time to give them their Synthroid. Probably now is not the time to give them their energy drug. Okay. Up next, we have PTU, polyuracil. On the flip-flop, this is used for hyperthyroidism. So when my patient has too much energy, too much thyroid hormone, this is going to help. However, this drug can cause agranulocytosis. Okay, so please make sure that we are assessing your blood count and things like that. This is also extremely hepatotoxic. So when we think liver, check your liver function tests. That's your ALTs and your ASTs. And jaundice. We all remember the Billy babies from Women, Children, Family, the increase in bilirubin, the jaundice babies. Something we got to think about. All right, now we get to talk about insulin. Specifically for insulin, please note the onset, peak, duration, and administration. Generally, when we're administering insulin, it's subcutaneous, but there are some insulins we can mix and there's some we cannot. Specifically, we're going to first start with our rapid-acting insulin. This is insulin Lispro. You must make sure that this is taken with meals. Meals shouldn't be on the way. Meals should be in front of them. Why? This will start working in 10 to 30 minutes. Remember, when a drug peaks, that is your biggest risk for a hypoglycemic event. That is your cool, clammy, needs some candy. Up next is short-acting insulin. This is our regular insulin. Okay, the onset for this one is 30 to 60 minutes. But remember, all the way from fundamentals lab, we learned how to draw up insulin. It was Nancy Reagan, RN. Push air into the NPH, push air into the regular insulin, draw up regular insulin, draw up your NPH insulin. Okay? Additionally, with our regular insulin, this is the only insulin that can be given IV. When we have patients coming in for a DKA or HHS, this is going in the IV. Okay? Again, watch for a hypoglycemic event. Our intermediate acting insulin, again, I reiterated the proper technique. But again, onset, peaks, durations. They're just unfortunately things you just kind of got to know. Maybe you can get a general idea. Okay. Our long-acting insulin, though, it has no peak. It is long-acting. Therefore, it's very low risk for hypoglycemic events. Speaking of hypoglycemic events, go review your Samogi effect and your Dawn phenomenon. Remember, these are essentially hypoglycemic events. Or not hypo, they're hyperglycemic events. So what happens with the Dawn phenomenon is at nighttime, we just didn't give enough insulin. So during the night, as they were sleeping and not getting insulin, that level continued to rise and rise and rise. So at 7 a.m. glucose checks, it was high. With the Samogi phenomenon, we've given a little bit too much insulin at night, or we didn't give it with a snack, so that when the drug peaked, it actually dipped them into hypoglycemia, and the body likes to compensate. So if my body becomes hypoglycemic, it's going to release sugar reserves from andipose tissues, which is going to spike my blood sugar. So with the Samogi effect, you still wake up and at 7 a.m. glucose checks, they're hyperglycemic, but what caused the hyperglycemic episode? With Samogi, it was a hypoglycemic that triggered a hyperglycemic episode. So in NCLEX world, your injectable diabetic drugs are for type 1 diabetes. Your oral diabetic drugs are type 2 diabetic drugs. In the hospital, yes, you will see type 2 diabetics get insulin, but for the purposes of class and NCLEX, the injectables are for type 1. The orals are for type 2. With our meglitides, this is an oral anti-diabetic, and I would just know that this helps my pancreas release insulin, which makes sense why it wouldn't work for type 1 diabetics, because they have no insulin. As much as we tell the pancreas to produce insulin, it's not going to produce insulin. Okay. Again, hypoglycemia, recognize your signs and symptoms of hypoglycemia, but this is to be given with meals. With that being said, if it becomes a really busy day and you end up skipping lunch, your patient shouldn't take this medication. It's specifically to be taken with food. Up next, we have glipizide and glyburide. They're the same drugs that do the same thing. Gliburide's just more potent than glipizide. Okay, this is really going to, again, stimulate the release of insulin. However, this can work a little bit better. And this also just overall prevents my liver from producing some glucose as well. So we're not only are we releasing more insulin, but we're preventing glucose production. So we really need to assess for a hypoglycemic event. Also, with this drug specifically, look at your sodium levels, as it can cause hyponatremia. And finally, we have metformin. We've learned a lot about metformin in our cardiac cath lecture. But really, metformin must be held 48 hours before or after a procedure involving contrast dye, because metformin really tanks your kidneys. So really, I think it's important just holding the contrast dye. Also, it can cause some lactic acidosis in patients with heart failure, so assess for pain, drowsiness, fatigue, and malaise. With metformin, because it's very harsh on the kidneys, we must avoid alcohol, eat kidney-friendly food, exercise, and drink lots and lots and lots and lots of water.